Welcome to Bone and Soft Tissue Neoplasms at bstneoplasms.com. We have our 53rd case answer. I think I put this up almost a month ago. It was titled The Throbbing Finger. This is a 60-year-old woman, throbbing pain in the distal phalanx of the thumb for 2 years. It was tender to touch. And this was the set of images that I had put up. And I had asked you whether it was osteoid osteoma, glomus tumor, inclusion cyst, or tenosynovial giant cell tumor. Let's look at all of them. So, an osteoid osteoma typically will look like an osteoid osteoma, except that in the phalanx, in the distal phalanx, and at the tip, because there is such little bone, the appearance is a little different. So here you can see this area with marrow edema, periosseous edema, little bit of sclerosis, which is better appreciated on the CT scan. Sometimes you may see the osteolysis, but these are the kind of appearances you would get. Our patient doesn't have marrow edema in the bone anyway. Inclusion cysts are again quite uncommon. This was one patient who had this growing expansile osteolytic lesion. We thought this could be infection, but in the end, this just turned out to be an inclusion epidermoid cyst. Tenosynovial giant cell tumors are typically T2 dark, as we see here, generally are along the tendon sheets, and they don't really affect the tip here. So that's unlikely to be the diagnosis. And I did do an entire case when we started bstneoplasms.com, and if you want, you can go through that. So if we look at the case here, what we have is a lesion that's intermediate to bright on T2, intensely enhances, but it's in the nail bed. And I think that's extremely important. In the center, it's bright on PD FATSAT and it is enhancing intensely. And see that there's subtle scalloping of the bone, but the bone is otherwise not involved and there's no marrow edema. And this is a classic glomus tumor. 83% of you got it right, and that's the diagnosis. Coincidentally, there's been a recent article in Skeletal Radiology, I think it was about 2 or 3 months ago, that talked about, this is probably the largest series of glomus tumors. A glomus tumor resembles the normal glomus, which is a neuromyoarterial structure responsible for adjusting blood pressure and temperature in the dermis by regulating blood flow. It's now called a pericyte perivascular soft tissue lesion. Finger is the most commonly involved in 51% as per this article, but like I said, this is the largest series. So the other half had glomus tumors all over, and I've had one glomus tumor in the lung presenting as a solitary nodule. So it can occur in other places, but this is the commonest. 77% of them are women. Of the finger lesions, 3/4 occur in the nail plate, and it's intensely tender to touch. So subingual would be the commonest. They ovoid, some of them may be round, little increased T1, bright on fat suppressed, and intense enhancement. But the most important is seeing them involving the nail bed. Now this one we have on the post contrast intense enhancement. But you can see that this one is a little larger and a little bright on the proton density FATSAT, whereas this one in a 24-year-old is the classic. It's T2 intermediate here again in the nail bed and intensely enhancing. So glomus tumors, when they occur in the nail bed, have typical clinical features. The patient gets referred to us as suspected glomus tumor, and our job is to identify the lesion and localize it so that the surgeon knows exactly where to put the small incision and remove it, so they don't have to search around. And even though the tenderness to touch may help with localization, sometimes that can be deceptive, so they need MR to do this. Ultrasound can also help, but again, it is not as good as MR when it comes to localizing glomus tumors. We must give intravenous contrast and do a dynamic study so that you can see the arterial enhancement as well. Don't forget the table of contents. Now we have 53 cases and a bunch of lectures, etc. That's my WhatsApp channel. If you like the other stuff I do, this is the case of the day I do Monday to Thursday. At CT Chest Review, I did this last Saturday, a snippet on the radiologist's role in pulmonary hypertension, and then a day later, this was the case I put up. Nobody actually does, no one's written about transfacet joint vertebral bone biopsies, or rather a transfacet route for these. And so, if you're interested, this will help. And then on Sunday, I looked at this particular issue on at atmasvas.com. You know where to comment, email, subscribe, etc. And thank you for viewing this. Take care.